Hello, I'm Ebbie Stewart. I'm chair of the Division of Reproductive Endocrinology at Mayo Clinic. In this video, I'm going to discuss what is new for uterine fibroids in 2018. As you all know, uterine fibroids are one of the most frequent problems for premenopausal women. They are non-cancerous growths of the uterine muscle that can cause a variety of symptoms. These symptoms include heavy menstrual bleeding and sometimes severe subsequent anemia, bowel and bladder dysfunction, looking pregnant when you are not, and also a variety of reproductive dysfunction has been linked to uterine fibroids. The first new thing is an increased understanding of the biology of fibroids, and particularly the genetics of fibroids. It is now clear that there are 4 key mutations that are important to fibroid development. Most of these mutations are somatic mutations, meaning ones that occur in the uterine muscle cells and change normal myometrium into fibroids. MED12 is a key somatic mutation in both black and white women and accounts for approximately 70% of all fibroids. There is a lot of research going on to try to understand why MED12 leads to fibroid development, and this will likely lead to new treatment options. However, it's pretty early in the understanding of MED12 mutations. It is, however, worth discussing the F8 or fumarate hydratase mutation too. Even though it is involved in less than 10% of all fibroids, FH is important for 2 key reasons. First, it is most often an inherited mutation that is transmitted in an autosomal dominant fashion in families. It is typically associated with skin or cutaneous leiomyomas, which is how you identify these families. Second, FH mutations can cause aggressive kidney cancers that are often metastatic at the time of diagnosis. So these families need to be referred for genetic counseling. These symptoms are called HLRCC syndrome, and that stands for hereditary leiomyomatosis and renal cell cancer syndrome. As clinicians, we need to screen for HLRCC syndrome, just like we screen for Lynch syndrome. There's also some evidence that FH mutations may be associated with an increased risk of leiomyosarcomas, which is another important reason to identify it in women with uterine fibroids and the syndrome. Switching from biology to treatment, hysterectomy remains the most common surgical treatment for uterine fibroids. Even with all the new alternatives to hysterectomy we've developed in recent years, hysterectomy accounts for almost 3/4 of all surgical treatments. What's new is that the long-term risks of hysterectomy, even when both ovaries are retained, are increasingly being described. Women with hysterectomy appear to have increased cardiovascular morbidity and over a 30% increased risk of coronary heart disease. These risks are greater in women who have a hysterectomy at a young age, such as often occurs for women with uterine fibroids. Some people have argued that hysterectomy should now be considered a cardiovascular risk factor. Thus, finding appropriate alternatives to hysterectomy is increasingly important for women with uterine fibroids. For the woman who wishes to preserve her uterus, there is new information on alternatives to hysterectomy. First, there is strong and substantial evidence of the safety and effectiveness of uterine artery embolization, UAE for short, when it's used for symptomatic uterine fibroids. There are 7 randomized clinical trials involving nearly 8,000 women that show UAE produces patient satisfaction and quality of life that is comparable to surgical therapy. Moreover, the risk of blood loss was substantially lower and recovery was more rapid than with surgical therapy. There is also good news for women seeking a myomectomy. Risk of retreatment appears low for women in their 30s at approximately 6 to 7% within 3 years, and the risk is 0% for women in their 40s. A large meta-analysis shows that blood loss and major complications were similar for myomectomy and hysterectomy when women had uterine sizes that were less than or equal to 18 weeks gestational size. While not approved for treatment in the U.S., there is an accumulating body of evidence for the effectiveness of progesterone receptor modulators, or PRMs for short. These drugs are oral medications given once daily and given in a cyclic fashion. Based on 14 randomized controlled trials with over 1,200 participants, PRMs have been shown to improve symptoms and quality of life for women with uterine fibroids. Based on a few cases of serious liver injury that occurred in the European Union, EU authorities have issued guidance for safety monitoring. It appears that these side effects are present in approximately 1 in 100,000 women. The guidelines describe including testing for liver function at baseline, monthly during the first 2 treatment courses, and at the end of treatment, and restrict therapy to women who are not eligible for surgical treatment. Undoubtedly, we'll be hearing more about PRMs in the upcoming year. So these are a few of the hot topics in uterine fibroids for 2018. Thank you for listening.